Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
Now then, our next guest is a medic who's turned tragedy into triumph after he's become England's first paralyzed surgeon. 2 years ago, Mohammed Bellal was left fighting for his life after being struck by a tree whilst he was out cycling. And now, after thousands of hours of rehab, he's back working with the help of special equipment.
Dr. Mohammed Bellal is a consultant urologist based out of Birmingham, UK. He specializes in complex functional reconstructive surgery. He's also the UK's first paralyzed surgeon. Dr. Belal has probably one of the most powerful talks we've ever heard about, which is called The Gift of Adversity. And we'll have a link to it in the show notes, and you can find it on YouTube. We just had to catch up with him after we heard this talk and saw some of the news clips about Dr. Belal. During our conversation with Dr. Belal, we explored a whole host of topics, including some pretty important philosophical concepts like the power of fate and how letting go of the outcomes of our life is such a difficult but powerful life lesson that we all need to learn. We also delved deeply into how Dr. Belal has adapted to his paralysis and has come back to practice as a surgeon, and his insights on how we might design the operating rooms of the future. Dr. Belal, thank you so much for joining us on the Cold Steel podcast today. It's really an honor and a pleasure to have you on the show, and thank you again for accommodating the time differences across the pond, so to speak. So thank you again for joining us. Can you tell our listeners where you grew up and where you did your training?
Sure. Yeah, thanks. Yeah, so I grew up in a place called Warsaw, which is actually not Warsaw, Poland, but it's a place in the Midlands, just north of Birmingham. It's actually quite a deprived post-industrial town. My parents were immigrants, and they came a year before I was born from a small village in Pakistan. And so part of the reason they came was they built a dam, and they flooded the particular place. And so lots of guest workers came over in the 50s and 60s. And so I grew up in a place, and I'm one of seven. I've got three brothers, three sisters, and my mother, she's illiterate. She can't read or write in her own language, let alone English. And so that was the sort of environment that I was sort of brought up in. And there was a lot of financial deprivation, but I have some very happy memories of my time there. There's a real sense of community, which perhaps we don't necessarily have. And through that, I managed to win a scholarship in the sixth form to a private school. And I was very fortunate enough to make it to Cambridge to study medicine. So I did medicine. I kind of always wanted to do surgery from a very young age. And part of that was I always had this thing about always doing the hardest thing. And in fact, part of the reason for doing medicine was because that was considered the hardest thing to do. And so surgery was considered the hardest thing to do. And so that's why I wanted to do surgery. And so I loved all forms of surgery. Pretty much any surgery I did enjoyed. And so I remember I really enjoyed general surgery, orthopedics, neurosurgery. And then actually one of my last jobs as a sort of a junior resident was in urology. And I hadn't really thought about urology. And what I realized in urology was that, there's so much variety in the operations as well. And I suppose your career choice tends to depend really on who you've met in terms of the people who inspire you. And the two urologists I knew at the time, they were the happiest-go-lucky guys. And so I was in this sort of pivotal moment of thinking about doing, in fact, ironically, colorectal surgery or urology. And in fact, I was about to go for a research job in colorectal. And the day before, they offered me the urology job. And actually what they said was, who do you want to be? And I think it's very much dependent on who the people you meet. And at that particular hospital, unfortunately, the general surgeons were all very angry on the second and third wives, and there was just a lot of infighting. Whereas the two urologists were the happiest-go-lucky guys, and they said, "Do you want to be like us, or do you want to like them?" And I remember that being the clincher. But equally, I can imagine if I was in a different place, in a different unit, it would have been exactly the same. There's always some inspirational general surgeon, colorectal surgeon, and all the colorectal surgeons and general surgeons have been fantastic. But it just so happened at that critical stage. So I was very fortunate to go for urology, and at the time it was very difficult. You had to do research, you had to do an MD, very competitive, and again, it was considered a very difficult specialty to get into. So, I must admit, I've never regretted my choice. And I think part of it is that you end up in a specialty which is very similar to your personality. And most urologists are, they work hard, but it's not as onerous on call as it is for, say, general surgery. And so they're generally a good bunch of people. But I kind of chose the hardest part of urology, which is the functional reconstructive urology, which ironically has a lot of general surgery. We do a lot of augmentation, cystoplasties, reconstruction, ileal positions. So in a way, I'm doing general surgery, but on the urinary tract instead. And also, there's a huge variety of operations. But the patients tend to be the more challenging patients, the sort of patients who've perhaps, have been moved from pillar to post and, seen lots of different specialists. And so that's the sort of part of me is always for the underdog. I think that's kind of me in a way, always for the underdog, and functional reconstructive urology, a lot of those patients perhaps don't necessarily get as good a deal. Oncology, generally speaking, is all, extremely well funded, and there's enough surgeons and enough theatre time. Whereas I think with a functional recon, the nice thing about it is I call it a thinking man's surgery, because you've got to think about what operation and provide a bespoke solution. Where, say, perhaps in oncology, in urology, it'd be like, just take the bladder out, whether fit enough to have the bladder removed or not, or you take fit enough to have the kidney removed or not. That's the only decision making you have, and the steps tend to be relatively similar. With functional recon, the variety of operations is quite significant. The patients are very challenging. There are times when you're thinking, okay, there's some really good patients, and there's some extremely challenging patients that make it difficult in terms of managing those. And so, the cohort of patients we get sometimes can be quite challenging, or, young women who can't void and may have underlying other issues as well, which you unfortunately can't fix as a surgeon.
I wanted to pick up a little bit on this thread of almost fate. You talked about this in other talks that you've given. Like, you talk about the day before choosing your specialty in urology as kind of this fateful moment where you had to make a decision in the day of. And then you also talk about when you have your accident, and we're going to talk about that in a little bit, realizing and right away kind of coming to terms with your fate. How does fate or destiny, I know this is a big philosophical topic,
Sure,
but
sure.
how do you think about that?
It is fascinating. I think as you get older as well, you become a bit wiser, and actually you see a lot of things happen. And so, you realize that there's all these forks and moments in your life that kind of define what happens. And actually, part of it is my faith as a Muslim, because actually in Islam, you have to accept whatever's written for you. And actually, that's part of the articles of faith. But what happens is you sort of get conditioned. Before my accident, the bizarrest thing, I had this premonition. I knew I was waiting for something, and I couldn't tell you what I was waiting for. And I still remember that sort of 2 weeks before my accident, I was out cycling with friends in a similar area, and I saw a tree fall in the distance. And I said to myself, how lucky would you be if that tree fell on you? Yeah, honestly, I remember the times. I have a very clear memory. And I also remember, we have this antique grandfather clock, which I normally wind up. And I remember, it must have been about a week before the accident, going to my son, who was at the time was about 14, 15. And I was like, look, if I'm not around, you need to wind that grandfather clock up. And he's like, it's like a typical teenager. What do you want me to do? You're always here. And so I remember getting to fight with him. And what's wrong with you? I said, look, he just needs to wind that grandfather clock up if I'm not around. She's like, what do you mean not around? And so the weird thing was, I had this sort of feeling, this premonition, I was waiting for something. And I genuinely couldn't tell what that was. And so when the accident happened, it was that kind of instant realization. We've probably done about 30 miles, me and my friend, and I just got in front. And I remember a very clear memory of the tree falling. And I do remember thinking, this is going to hurt. And the next thing I remember, I just remember dreaming, and this sort of seemed like a very positive dream. But then I was like, the last thing, my last memory was the tree. And that's when I then got up, or tried to get up, is when I realized I was paralyzed. And it was at that moment I had this sort of realization that, this is what I was waiting for. So, it became sort of crystal clear in my mind. But I'm an eternal optimist. I was thinking, yeah, okay, all right, I'm paralyzed. Yeah, it'll be a few weeks and I'll be fine. Yeah. And so it's amazing, at the time, partly being a medic, I mean, obviously the pain was the overbearing thing, really. And, as a medic, you always say to someone, look, what's the pain from 0 to 10? The 10 being the worst pain. Having experienced 10, everything else kind of slides that way. And as you can imagine, it was the worst pain. And so it was weird. I had this visualization of myself in a wheelchair, And then the second thought, it was going to be a long journey. And so that sort of acceptance at that time. I mean, the weird thing was if you'd asked me 6 months earlier, how would I feel, being paralyzed, I would say I'd be absolutely devastated. And the weird thing was there's none of that devastation. There's a degree of calmness that I've not really felt, and it's very difficult to describe that. And I think there's a sort of spiritual element to the whole journey as well, really. I mean, I think if you think about it in terms of probability, it's not a windy day. I'm going 40 kilometers an hour, and the tree falls at the exact moment I go by. You could say probability, but it becomes meaningless. And so, for me, the way I look at it is I saved my friend's life. It was a millisecond the other way. It would have decapitated my friend. And I don't see it as a negative thing. I see it as, look, I saved my friend's life. It was a little bit, he's about 10 years younger. He's got more life to live. And the second thing is, I think that helped the journey an enormous amount, just letting go at that point. I think as surgeons, we find it very difficult to let go. And I always had that problem, previously as well. When things haven't gone well, you've had complications, you get very frustrated, and and so, when you do let go and accept something, it actually makes things a lot easier. And so, in a way, I was extremely fortunate. It wasn't anyone's fault. It wasn't like someone rang me over in a car or someone's responsible. It was just such a freak type accident, but it had to be my fate. The way I kind of see it is if I was walking, the tree would hit me. If I was in a car, the tree would hit me. And the weirdest thing I've done is it was quite funny. 4 years after, I ended up in the same place, and they chopped the tree and the segments of the tree. So I'll take a part of that tree, and it's drying out just in my foyer, because that's part of who I am. It's just you know so I don't have any sort of post-traumatic stress about trees. I mean, my friend unfortunately did, but you have to sort of own it. And like for me, it's that tree and me are intimately linked. I haven't decided what I'm going to do with that bit of tree. I might just sort of chop him, maybe frame a bit of that tree. But I'm yet to decide.
So powerful to hear you speak about this because, like, as you say, about, I think in general for people, but particularly for surgeons, we really, like, if we have a bad outcome, we really own it. And it's, you just sit there and then you have, our morbidity and mortality rounds. And then everybody's like, well, why did this happen? How could we prevent it? And of course, unless we do that, we will not make improvements, we'll not get things better. But there is an element to that of realizing that there are things that are not within our control. So is this realization something that you've always had, or is this something that your accident actually taught you?
Yeah, I think it's a combination of both. I mean, I think earlier in my career, I used to take complications extremely badly. Obviously, you learn from it, but, I just couldn't sleep for days. And I think that's not a long-term strategy as a surgeon, because invariably we'll all have complications. So over time, and I think it was the COVID period as well, that realization that actually so much is out of our control. So even the surgeons in Birmingham, which is the sort of second city, it was one of the highest hotspots for COVID. And so even as urologists, we had to do COVID wards, look after all the COVID patients, COVID ITU, and it was that realization that actually a lot of things are out of your control. You can only, and surgeons, we're control freaks, and that's the problem. If you can't control, we get stressed out. But I kind of learned that actually, it's an ultra marathon. And so to have that sort of resilience to carry on in your career, you have to at some point say, listen, of course I'm going to get upset, but actually I've learned from this, but I have to move on. Like, otherwise, I mean, I always say it's all your major complications leave an indelible scar on you. And that's why all surgeries become more cantankerous as time goes on. And you see that all the time, because each time you have such a significant complication, a problem, either have to go to coroners or you've got to have an investigation, it's like multiple jeopardies, and it leaves indelible scar on you. And it's almost like a post-traumatic stress experience. Certainly in the UK, you can refer to the GMC, the coroners, internal investigation, external investigations. And so a single sort of moment where things haven't gone well, that can cause you problems. And so it's about, having that sort of resilience to then carry on and say, well, look, yeah, of course I'm going to learn from it. But actually, there's an optimal amount where you can't be the sort of person who really doesn't care. But equally, you can't be the person who cares so much that kind of paralyzes you moving forward. So you've got to sort of find that happy medium in between.
It's really powerful, and I think something we all need to learn from and understand. And I would, support what you're saying about how your spirituality, your religion plays into this as well too, because I think there's a powerful element to that across many traditions that tell us to let go of the outcome, right? Focus on what we can do and how we can learn from things, but to dissociate ourselves from the outcome. I mean, you speak so wonderfully about going through this whole process. I don't think I've ever laughed so much. There's a talk that you gave at a urology conference, I believe, maybe in Michigan, if I'm not
That's
mistaken.
right. Yes.
And I don't think I've ever laughed so much listening to someone talk about getting paralyzed as when I listen to your talk. Like there's one line in there where you say, at least I have the Strava. The Strava is forever. Pain is temporary, but Strava is forever. And you show, the whole route up until this moment. But can you tell us a little bit about what that experience of being on the other side of the table, like that's such a powerful trope within medicine. There's all these books, movies about people, the physician or the surgeon who suddenly is on the other side of the table and having to see things differently. Can you tell us about that?
Yeah, no, definitely. I mean, I think it's hard actually because, the longer you're in medicine, I wouldn't say you become desensitized. You do to a degree, especially the pain, for example. I mean, how many patients go through pain and you become not numb to it, but you don't really appreciate it. So actually, for me, it was an eye opener. I mean, there's a couple of things this sort of opened my eyes to. Firstly was, I had amazing care from everyone, from every single healthcare practitioner. And sometimes being a healthcare practitioner, you forget that actually your daily occupation every day you go in to help people. And over time, you can become jaded by the politics, by the structure of the organization you work in, etc. And it sort of made me realize how fortunate I was to have so many people who were dedicated, and so we all go through sort of different phases. And so for me, it sort of rejuvenated that sort of love of medicine. I've always had a love of surgery, and there's something very special about surgery. But on the other side, I kind of learned so much about, what I thought as a surgeon was important and what the patient thinks are two separate things. As surgeons, we tend to be goal oriented. Okay, we've got to get all these sort of complications and these risks all put in, but that's actually not what the patient necessarily wants. And so I kind of learned the importance of really not trying to rush them, just giving them the time. Your time to them is really important. And so I call it the first minute. So every time you see anyone, any clinical encounter, just give them the first minute. Just try and work out what they want. Because actually, quite often, we're very quick especially surgeons, very goal-oriented. Look, we've got to quickly consent the patient. We've got to quickly do that. The other one is about communication. And the communication is interesting because I think what we fail to realize is about the human spirit. And the human spirit is that we're inherently positive. And so what happens is that, like, sometimes, one of the things is we tend to do is keep on, we need to tell the patient everything straight away. But actually, the patient doesn't need to, he needs to break down whatever's happened to him into, there's too much to absorb. And so we have to have sort of serial points where we tell them a bit more. And I think sometimes, I kind of learned sort of, the way you just regurgitate everything, the patient's not going to take most of that or will be numb to half of that as well. And that realization that they have to have time to come to terms with whatever you're telling them. And that could take a bit of time. It may take more than one consultation, and not keep on reiterating the negatives. There's no point telling a paralyzed guy, if you tell someone who's had spinal collision, you're never going to walk, you don't have to tell them more times than that because they'll remember that moment. Yeah. There's no point coming back and say you're never going to walk again because you're just hitting them with the hammer. Yeah. They know they're not going to walk again. Do you see what I mean? And so sometimes as medics, we do that. Sometimes we go, okay, I don't think he quite understood that point, but I'm going to tell him again. Yeah. And so whenever you've got something adverse, people remember. On the patient, you remember. I remember absolutely everything that was said to me. So now I kind of realized that actually, we try and make it very black and white, but it isn't black and white. It's shades of gray, basically. And we tend to be definitive in what we say, but actually it isn't definitive. And the patient has to say, well, I always said to myself, look, no one knows what I'm going to be like in 2 years. Yeah, and they're very good to me because they didn't actually say to me, never going to walk again. Because I bloody knew it, they knew it, but actually it was unsaid. Whereas my wife was more like she wanted to know. And I'm like, listen, I prefer the uncertainty because that's the way I kind of found having uncertainty helped me because no one could say to me, you're never going to do this, you're never going to do that. Whereas my wife just wanted, black and white definitive answers. And so it's trying to work out what the patient wants, but also recognizing that actually it's not always what we want, is what the patient wants. And it's hard sometimes. That's why you need that time, and I think that certainly in the National Health Service, you're extremely stretched for time, but actually that's the best thing you can give the patient is a bit of time.
I have to pick your brain a little bit about this uncertainty versus certainty piece because, on the flip side, sometimes it feels like when we're talking to patients that we don't give them enough information, or we're things are too uncertain. Like when we see people with rectal cancer that, for example, we don't want to do a radical resection for, we want to watch non-operatively, and so we give them all these probabilities, and they're like, well, what am I supposed to do with that, right? They sort of look at you blankly and they say, well, what should we do? Should we have surgery or not? So there's an uncertainty piece to there that it seems like patients really struggle with, but you're sort of, and I think this is also tied up with what you've talked about in the past with hope, right? Like there's some way that we can deliver this information, but also not take away people's hopes or abilities to actually try to achieve things and push themselves. And we hear these stories all the time where someone says, you'll never walk again after getting some sort of injury, and then they do, and they prove everyone wrong. There's obviously no one definitive answer in all solutions, but what are your insights around this?
Yeah, so I think the thing about the hope is really important. I think humans are incredibly hopeful. It's how we phrase our language. And so, for example, even if you've got spinal cord injury, the chances of you walking isn't zero; it's 3 to 5%. Instead of never saying you're never going to walk again, you say, well, actually, it's unlikely. But you've not used the word never, and it only becomes an issue if, for example, given that particular example, the patient, every single spinal cord injury patient thinks they're going to walk. They think they're going to be the one that's going to walk, right? And that's, if you ask anyone who's been through, a couple of years within, they'll all say, yeah, we thought we'd be the exception, yeah, and it's never zero. And but that hope is what keeps you going. And the same with when you tell patients complex stuff. I think the problem with the direction of medicine has been is that sometimes information is too complicated for people to make a reasonable decision, and quite often, it's a shared decision making, and you have to help them along that journey.
I'm going to remember that phrase, the first minute. I'm going to take that with me and really try to implement that, because I think you're so right that we often don't even give them the 1 minute to let them just say their piece and try to understand who they are as a person. So I'm going to take that back with me.
Yeah, I mean, remember, surgery is not just about surgery. It's actually, the thing I kind of learned was that relationship that you have with your surgeon, and I went through multiple surgeries, and I was terribly grateful for the skill of the surgeons who did my surgery, because I realized, look, and that's why I think surgery is more than just physically doing it. It's how we interact with them in the clinic, and the words of kindness is actually part of what we do, and I think that's really also important for the therapeutic aspect of the relationship. And I kind of understood that when I got all those letters from my patients. It was extremely humbling. And that's what kind of drove me to come back, because you kind of look back and something's terrible has happened, and you say, well, what have I done with my life? But actually, once I received those letters, I realized, look, my life wasn't wasted. It's in the service of others. It's helping others. But the weird thing is that what you don't realize is that, I didn't quite realize how much of an identity being a surgeon is. Like, it's such a big, important part. And so when I had my accident, I actually, I felt hollow on the inside. I felt that sort of lack of purpose. And I think a lot of disabled people or spinal cord injuries probably go through that feeling that they feel like the value to society, or the value, and that I hadn't realized. I mean, a lot of jobs you don't have that same sort of satisfaction as you do in surgery, but it becomes an integral part of your psyche, and that's how you identify yourself. And so for me to come back, I can't tell you that feeling of happiness, but there's something special being able to do something with your hands, and I was extremely grateful I still had my hands. And so that for me was a real blessing.
This is a surgical podcast, and this segues really nicely into talking a little bit about how you made that comeback. So yeah, I mean, you talk about like recognizing very early on, like, look, I'm paralyzed, but I'm going to come back and I'm going to be a surgeon again, and I'm going to operate. I couldn't agree with you more about how much surgery is part of our identity as a human being, right? Whether that's right or wrong, that's just how it is. Can you talk to us a little bit about how you prepared yourself to come back to being a surgeon? Because you again, you've talked about this. What was sort of the process of you, practically speaking, coming back and practicing again?
Yeah, I mean, I think one of the things was I was a bit unrealistic. I gave myself a goal of 1 year to come back, and looking back, I needed that goal at the time. But what I kind of realized psychologically, which really helped, was not to fix too much of the end journey. And I was like, look, listen, I'm going to do all this whole series of things to get me there. But it doesn't really matter. Like, not so much focusing on I'm going to be back as a surgeon, saying this is what I want to do, but letting go that I may not achieve it, but I know that actually I'm going to try my best. And and sometimes, you do have, like, the problem is there's so many things to overcome from a physical point of view. And I kind of realized that, look, I'm the master of my own destiny. There's things that I can do which can help. And that was that kind of relentlessness of doing the rehabilitation 3 hours a day, and then just that relentlessness of getting that done, having that mindset, this is my new job every day, every day. Yeah, this is I need to get 3 hours done every single day.
No surrender, no retreat, right?
Yeah.
Yeah.
That's right. No retreat, no
Retreat.
surrender. Yeah, and so that was helpful, but I think I was still quite unrealistic. And the thing I realized was that actually, surgeons, it took a year for my spine to heal, and that was difficult because as surgeons, we're very goal orientated, we want to rush things through. And there are some funny moments. I came back from the hospital after 4 or 5 months with this brace, and I said to my wife, I'm going back to work next week. She says, of course you are, dear. Of course you are. This is crazy. This is crazy. There's no way I was going to go. But it's just human. He goes, yeah, of course you are. Of course you are. Of course you are. And that's usually me along. But so I think the thing was I kind of set myself that goal, but I realized that it was going to take a long time. And it's only after my spine healed, about after a year, then I realized, look, listen, I still need a lot more time before going back. And so I was very fortunate that I was able to access this private facility and go through all the equipment. And I made it very clear what my goals were, and they were incredibly supportive. And so it took a longer process than that. But actually, one of the key things was really the support of your colleagues. So that's critical, really. I think one of the interesting things is that what goes around comes around. And my consultant colleague, Tom King, he was my resident and my fellow. And actually, he we appointed him about a couple of years before my accident. And so the tables are turned, and I couldn't have gone back without him. And so I think you can't achieve stuff without the amazing people around you. And all my colleagues were pretty fantastic. But it's not even just the colleagues; it's the theatre staff. So I've always had a positive relationship with people, and I think that really helped. And it's that sort of support of the community and people around. But actually, you know, it took a while. I had to get my colleague to push on the inside. I had to push on the outside, and because there's so much uncertainty, like they hadn't done it before. But actually, the communication was open for a while to say, well, look, this is what I want to do. And I was incredibly fortunate that the occupational health, Helena, was brilliant, and she helped facilitate a fair bit. But then it became psychological. Then I knew, look, I was going to do it in a year. I set myself a goal at 18 months. And my wife is very good because she's a psychologist. And because whatever happens, you adapt to whatever situation. And as a surgeon, you're like, how can people stay at home? And how does the day went so quickly, it was unbelievable. And it's funny because now I look back and I said, look, you had it there. But at the time, I remember, like, you get in the morning, do your routine, whatever. Before you knew it was the afternoon. And so it's incredible. Your day expands to whatever you've got in there. You then get used to it. And I remember my wife saying to me, she said, look, yeah, if you don't get back within the second year, you're unlikely to get back. And that's exactly what I wanted to hear, because it's very easy to stay in that comfort zone and say, well, I'll give it another 6 months. I'll give it another 6 months. But I think it was just running through that kind of thing of having that practice day of having the equipment ordered, going through the whole process and having the team with you, that kind of gave me that confidence. And a lot of it's about confidence for you and confidence for everyone around you, because there's a lot of uncertainty, in coming back.
Can you talk just a little bit about the actual chair that you use? Was that something that like someone else had used, another surgeon had used, or was that something specially designed for you? Can you talk just a little bit about the chair? I've seen like a clip of
Sure.
you using the chair. Yeah.
Yeah, so the chair, there's lots of different sorts of chairs. There's a vertical standing chair, and I tried those, and when I went through the intensive rehab to see how it would work, and so I chose the chair because it had the most functions, and I kind of realized that look, as surgeons, we're problem solvers, and we'll have to adapt. And in fact, I've had to adapt my surgery accordingly. And one of the things was initially I was sort of saying, look, I need to be vertically standing, but actually the problem with vertical standing is after about 45 minutes, the blood pools down your legs, you start feeling faint. And so instead, now I have it in a sort of high up, leaning forward, and I tend to operate in the pelvis, in that fashion. And then I have to switch it around after 2 hours once the core goes on that side. So the thing is that chair is at the top of the range Permobil, which is an American company chair, which allows vertical standing, but it has lots of tilt forward, tilt back functions as well. So I chose the chair which had the most potential that I might need. But the problem really with surgery still is that you have that central pillar and you can't quite get close enough. And so you do sort of operate from a mechanical disadvantage. Whereas as a surgeon, you're generally above the patient, really, when you're operating, and a lot of reconstruction is done open. And so you kind of vertically above. And so that does make it a little bit more challenging. But that's why you need that sort of intensive physio that I do about 10 hours a week myself, keep myself in tip-top shape.
The reason why I asked you about the specifics about how you do the operations is because I think there's a lot that could be done in the way that we've set up the operating room to facilitate folks who may have disabilities in the operating room. But also, there's so much interest in ergonomics, right? In setting people up long term to have long, healthy careers. So I'm really interested in what mechanistically this looks like. So, when you're deep in the pelvis, so tell me again, the way your chair is actually has you leaning forward over top. And how do you kind
Yeah,
of get the angles that you need to be able to see low in the pelvis and actually be able to retract things and operate? Do you use your assistant in a different way than you used to?
I've tried lots of different positions to work out the optimal amount. And what I've kind of realized is, I have a sort of guard to sort of counterbalance me so I sort of lean forward. But actually, sometimes you have to sort of get the patient sort of tilted to the side so you can see easier what's going on. And so there's all these little sort of tricks that you sort of pick up. And equally, down in the pelvis or perineally is much easier. You're pretty much there. I think, as surgeons, we're problem solvers. You sort of try and eke out what is the best sort of position for you. I mean, my long-term aim is to try and move on to the robot, but with functional recon, there's not many operations done with the robot because they always redo surgery. And that would be ergonomically better, but I do understand there's a foot pedal that they may have to adapt that. And so the weird thing is the simpler operations like a TURP where there's a foot pedal, I've not actually done that. I've done the big cases. I haven't done the small cases. And one of the questions I was thinking about was what are the operations I don't do. I actually no longer do this. The classic operation of urology, which is the TURP. But even with that, I've kind of thought about how can I do that operation. And what I realized is I'd have to get a table on the side and use my elbow for the pedal instead to do the operation. And so there are ways you can overcome it. But you're right, the ergonomics, I think theatres aren't really set up. It has to be an electric opening door. There has to be a great amount of space in the theatre. So the size of the theatre has to be a little bit larger as well. And also in terms of scrubbing up as well, probably needs a little bit more space there as well. And so you can adapt it or up or down in terms of the sort of position of where the taps and so on. But there's definitely ways you can sort of improve the ergonomics for the disabled surgeons.
So, having gone through this experience, do you think that there's so you talked about having operating rooms that are bigger, the scrub sinks. I didn't even think about that, but like it totally makes sense what you're saying about the scrub sinks having to be designed differently. What has this whole experience taught you about perhaps the way we should be thinking about operating rooms, equipment in the future? That, like as you pointed out, even the foot pedal, it's kind of funny that we still use that in a way, right? Like I'm not even sure that it's
Sure.
so, like when we do gallbladders or lap cases, we always operate the cautery with our foot, which in some ways doesn't make a ton of sense. You're standing on one foot. It could easily be embedded in the actual cautery. The L hook, it could be embedded right in the cautery itself. So, anyways, I'm sure there's lots of things, and perhaps no one size fits all. But do you think moving forward in the future, there's ways that we can design our operating rooms and our equipment to accommodate more people?
No, definitely. I mean, I think that what happens is most of the equipment is built on tradition, what's happened in the past. But actually, you almost need that kind of revamp, like you said, of the equipment. Why are we doing this way? Why are we doing that way? It's sort of built incrementally. And actually, I think with AI and robot, I mean, that probably gives more accessibility in a way, because then the ergonomics generally tend to be a bit easier, robotically perhaps than sort of, classically with laparoscopic shoulder breaking surgery with the shoulders. A lot of the surgeons get shoulder problems. And you're right, the ergonomics are important. But you see, the problem is no one really thinks about the sort of accessibility issue. We all assume also, that actually, but actually the reality is in most surgeons' careers that they will have physical disabilities as time goes on. And actually, if you want to keep the longevity, we have to think more carefully about that. And there's a certain degree of macho-ness to surgery that, oh, well, you just got to carry on, you just got to overcome and surgery it. But actually, you are asking them pertinent questions that actually we do need the surgeons not to retire early to sustain their careers. And that vast experience that they've got, I'm sure there may be some reduction in amount of dexterity, but the experience then tends to make up for it and mentoring the next generation. But I think what tends to happen is that I think that it's good the newer generation are thinking about that and also thinking about longevity of people's careers.
What do patients say when, I mean, it's not like it's a secret that you're paralyzed. So when you go to see patients and they realize, oh man, this is the surgeon who's going to be operating on me, what's sort of their reaction, and do they ask you
Yeah,
any questions?
no, it's fascinating because I mean the ones who know me, who knew me from before, the disabled patients, is a much better interaction. There's a lot of unsaid things. And patients. It's interesting how patients, or the ones who've known you before, the people say, "Oh, I didn't realize that's new, being in a wheelchair." So, like, well, and they're fine. Actually, you can have a laugh and a joke with them. But actually, the interesting thing is that people do. A lot of people work. I mean, in the English culture, people are generally quite reserved, and so it becomes an issue afterwards. I remember seeing this lady. We were doing the vesical vagina fistula, counselled her, and there's only later that she rang up the specialist nurses. Are you sure you can do the operation? And I said, look, I said to my specialist, tell her, look, if she's not happy, we can refer her down to London. It's not an issue. And she's like, look, he's the main surgeon, he can do the operation. And actually, in a way, we did the operation, it was all a success. But on an individual level, I've broken her perception of what disability is, and so one by one, you change people's perceptions. I have no qualms about people saying, look, they don't want to get operated. I mean, that's perfectly fine. But you are right. There are times when you just meeting the patient for the first time, just before operating. I remember this lady, just seeing her, I could see the shock in her eyes, and the sort of terror in the eyes, and I sort of joked and said, look, don't worry, I've done this operation 100 times, you'll be fine. And actually, it's and I think it's difficult, isn't it? Because people have perceptions about people in wheelchairs, and we all have perceptions about prejudices about lots of different things. But the way I kind of see it is I'm breaking those down on for that individual person. Their perception of disability is very different. Once you tell people that you can't do this or you can do this, it's an eye opener. And so there's this very famous experiment that was done with these sort of flies, and there were sort of jumping flies, and there's what they do is put them in a container, and the jumping flies they just then put the lid on top, And these jumping flies could jump out of the container, but they waited for a generation until the little ones were born. They took the lid off, and the adult ones got conditioned to not jumping out. And they taught the little ones not to jump out, and they could all jump out of the lid. And that's what expectation does to you. And so people's expectation is one of the things I kind of talk about is, I'm sure everyone had this expectation, I wasn't going to come back. And so it's breaking those. Basically, it's being honest and said, look, as surgeons, we can't get on with everyone. And there'll be people who, you can't overcome this or prejudice or the concerned, and that's fine too as well. It's not a problem, but you are right. It is interesting. So I always try and see the patient beforehand, but sometimes you just turn up on the day and that's the first time they've met you. But most people will, once you reassure them and say, look, it's not a problem, most people will take it at face value.
This has been such a fabulous conversation, and I really have learned so much from you, how you've handled the curveballs that life has thrown at you, but also what you've learned from this whole process and how we can bring that to be better surgeons and better clinicians. I'm curious, and this is a question that we ask all of our guests on the show. If you could go back in time and give yourself advice as a senior registrar, maybe, or an early consultant, having gone through what you've gone through now, what advice would you give yourself?
Yeah, I think I was thinking about this. I think in terms of advice, I'd say, well, look, I think as surgeons, we're extremely passionate, goal-driven, and we get very upset about lots of things. It's about actually, I call it the sort of 2-week rule. The things we get very cross, angry, irritated about, actually, most of them do not stand the 2-week rule, because in 2 weeks there's some other issue that you get upset with. It's actually still recognizing being a bit more strategic early on in your career. And I think maybe that happens with experience and so on. It's a sort of saying, well, look, the day-to-day is not as important as a sort of a longer term, and not being so reactionary. And sometimes we tend to be reactionary, certainly early in our careers. The number of emails I wish I never wrote. Yeah, so it's that whole thing about just putting in draft and just letting it go, because no one can wind up surgeons as a healthcare system, and then we're incredibly passionate people, wanting our best for our patients, and we're very driven. But it's having that sort of balance of just saying, well, look, not be less reactionary, try and work out, okay, how can we improve things in the long run, and being patient to say, well, look, change is not going to happen in a few weeks. It's going to take months, it's going to take years, but the overall trajectory should be upwards. And it's about building those relationships with your colleagues. I think it's really important. And that certainly paid for me. I wouldn't say anything different. I'd always be this and being authentic, really. And I think it's really important to be consistent in general terms. But for my past, I'd definitely say just put those emails in draft. Just don't send those emails, because you're reacting, and it's very easy to react early on. And actually, I look back at some of those decisions, and I'm like, well, clearly it wasn't the right decision. But at the time, I was 100% certain that was the right decision. And that's the thing. We're extremely, type A personality-driven people, and we're very passionate about a lot of things. It's just that kind of balance. You have to drive, but sometimes we drive too much, and it's that kind of, finding that balance, really. Just working out what the important battles are, not wasting your time on those battles which are inconsequential in the long term or in the medium term.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.